In SLAM, in the South London Maudsley, they have the enormous privilege of being able to do a search on homelessness by free text. So they can actually search homeless for the admissions, which we can't do in most of the acute trusts. So they very kindly did a search for us and sort of showed that in the year previous, that the admissions coming from people that had that free text word, the cost of that was 2.7 million in the past year. So that was quite useful to kind of focus them. And at the same time, we came across the very amazing Alex Tulloch, who's a psychiatrist in the trust, who'd actually already been working on this and done a much, much larger scale piece of work, going back retrospectively over, I think, about 10 years, who had shown that homelessness was associated with a 45% increase in length of stay. So you'd think then, wouldn't you, that when the needs assessment went in and the CCG were thinking about funding a pilot, they would have immediately thought that they should include mental health, but they didn't think that. So the pilot was funded for Guy's and St Thomas's and King's, but not for the South London Maudsley. So Nigel and Rangarao and some other partners put in bids to the Guy's and St Thomas's and SLAM charities to pilot what was actually a 3-year pilot of the service, which has just finished. So what I did do is I was there for the first 6 months, setting up the service and actually trying to find out really what the service should be about. And I suppose as a physical healthcare nurse, my main reflection and surprise was about the whole care coordinator system. And obviously there's a set of people in a mental health hospital who have a care coordinator, and that care coordinator is responsible supposedly for meeting them in hospital and developing a pathway out for them. But there was a whole section of patients who probably belonged to us that were frequently been coming informally or in a section 2, or perhaps coming through the sort of the 999 suites, who didn't have a care coordinator, and actually a lot of the people on the ward didn't feel it was their responsibility to find do a safe and effective discharge for them. So really, my role was to kind of understand who we were going to work with and advertise the team. So I will tell you about the referral criteria, then I'm going to hand over to John, I think, because we haven't got much time. I will say that, so John Sapani is the lead OT on the team. Actually, I don't know whether that's true. Are you joint leads?
Well, we are, yeah.
You're joint lead?
we don't use lead in our team.
Eamon McBride is the other OT on the team. And I haven't met Sherelle, actually, but Sherelle Greggs is a housing worker on the team. So when it comes to questions, then you're not really going to be directing them at me. But just to say, the referral criteria from the paper was that they needed to be, obviously, an adult living in a homeless hostel, B&B, sofa surf. So it was any kind of definition of homelessness, that didn't matter. And with any mental health diagnosis, which was and is still slightly different to the way mental health services are constructed. But we did decide to exclude patients with a care coordinator, and specifically just to say that there is a START team, so there is a psychiatric mental health community team in that area for whom the pathway team works very, very closely with, but it is their job to work with the people that are under a Section 3. I notice Zana did put some stuff in about what you were talking about, but I think we've covered that.
I've already got a microphone actually, so it's fine.
There you go.
Yeah, so I'm just, as I said, like Sam, I haven't really, this was kind of thrusted upon me, so I don't really know much about it, but I can tell you about our team. So as I said, I'm an occupational therapist by profession, myself and Eamon, and we've got Sherelle just started in our team as a housing worker, but both me and Eamon work as mental health practitioners, being in a mental health service. So it's a large mental health service. We cover Lambeth and Southwark, but patients come from all different types of boroughs. And when, as Sam rightly mentioned, we only deal with people who don't have a care coordinator for reasons that she's mentioned, but there are other housing services that kind of support them. We do joint work with the care coordinator, because often they're just being referred that care coordinator, and a care coordinator is a caseload of 50 or 70 or whatever, and that homeless person is last on their list. So sometimes we do a bit of joint work just to support them along the way. So when we're thinking about, we spoke about referral criteria. So when the patient comes in, we get the referral from wherever the ward, and we check systems. I'm sure you guys know what NHS Spine is? People know what spine is? It's fine, I won't talk about that. So we know what chain is? So chain is a rough sleeper database, and that is a rich source of information about services they've been linked to. These might be homeless services, their length of time, rough sleeping, if there are any plans already in place. So that kind of helps us to think about what service we can contact to kind of help them along the way. And we start by, basically, if they do meet our criteria, we start by doing a holistic needs assessment, which will cover areas such as social care, physical health, mental health, as well as housing. And I guess the main point around that is housing is not the only solution. I think that has been mentioned across the board within this conference. And being clinical occupational therapists, we are looking at the health and physical health and mental health needs to basically ascertain what is the safest route for discharge, what kind of, I would say, evidence do we need to present to the ward to ensure that that person's discharged safely to the right accommodation and having the right support. Yeah, we just go up, yeah, it's fine. I mean, just gonna quickly just mention in terms of follow-up, and I guess the main aspects is GP registration, ensuring people have GPs, really, really important. I think GPs are still in a kind of transition in terms of accepting that people do not need ID, they don't need to prove their address. So often that is our first challenge, actually, people who've got nothing, because usually with homeless people, some people have lost their ID, they don't have any ID, they don't have anything. But just thought I'd mention that point. So services we work with, there's a whole raft of services there, but I would mention the START team, who we work quite closely with, and they work with the really entrenched homeless people. So when they are referred to us, if we feel that START would better meet their needs, we will refer to them. And we also meet them every Tuesday to discuss cases. Southwark Law is also quite a useful service that we work with, and just to get the kind of legislation, because I'm not a lawyer, I don't really know that aspect of it, but they can give advice around that. As you can see, local authorities, night shelters, routes for home, no recourse, interpreter services. So the whole list of services there that we work with. So I was going to move on to the next one. Oh, how do I do that? I haven't got that. And in terms of intervention, I think one of the most important ones is advocacy. And I think people would agree with me, particularly being in a hospital environment where bed pressures, funding, I was told by a bed manager there was 11 people coming in, so what's happened with your one homeless patient who's going to make the whole load of difference for the 11 beds that are needed. But often we find ourselves in a position of having to provide evidence to actually challenge the ward in not discharging people prematurely and ensuring people's needs holistically are looked into. That kind of challenge happens more than I think it should. Personally, I think hospitals should understand that holistic need, but advocacy is a massive role that clinical staff and housing workers also play. Practical assistance, really important. I think some of the basic things like ensuring people have clothes. Some people come with no clothes, no clean clothes, travel assistance, community accesses, frequent attenders we've kind of mentioned, and I think advocacy and challenge and practices kind of go together. And identify missing persons, that happens a lot. We often find ourselves to be sometimes investigators and trying to trawl through the loads of information to find out who is this person, and then you suddenly find who they are. So what's this been? Who you've seen? All right, so these are the type of people we see. I mean, that kind of categorizes a whole load of homelessness. And when I say homelessness, it's not your kind of obvious street homelessness. You deal with rough sleepers, sofa surfers, people living in inappropriate accommodation, temporary accommodation, also people who've been trafficked as well. I'm actually dealing with that case at the moment. Is quite a challenging case. But these are the kind of rougher people that we see. And then when we talk about transitional work, I guess it's thinking about those people that are quite high risk. And there's two kind of sets of people. There's the people where you've had to find quite a quick interim plan, because we also have to bear in mind the needs of the hospital to discharge people if they don't need to be in hospital. And we will continue that work with them, either with housing or other things. And being occupational therapists, we would like to work with people forever and ever, ensuring they got all their hopes and needs and educational needs and everything put in place. But again, it's just following them up, making sure they are taking advice, moving to drug and alcohol services. And sometimes things are not always in place, like benefits and stuff like that. So we'll keep them in our books and continue with the transitional work around that. Yep, and so this just gives a list of the type of people to see: severe mental health, schizophrenia, emotionally unstable. I would say the personality disorder patients are often the most difficult to deal with, not because of them, but because of how they're received by the hospital and the challenges you also have to make. Sometimes it's not essentially about the mental health need, but it's about making the hospital understand the needs of the patient and how they're going to manage in the community and how that personality disorder does an impact on them. Yeah, so these are some of the outputs about what we do. No recourse is quite interesting, 124%. We often have found ourselves in a position of having to advise the wards about mental health to mental health transfer in other countries, and we use that to kind of boost up our data about reconnection, which is good. And improved housing status is a really important one as well. And that's not just about getting people into the right house, but ensuring they've got their needs met and they're in appropriate accommodation, I think is really important to mention. Yes, and eviction or housing loss prevented as well, which is quite important. I think that's quite an important point because often people who are evicted are not evicted due to fault of their own. It might be in the context of their mental health. So they come into hospital, there's the issue of intentional homelessness, but as occupational therapists, we can kind of provide the evidence to establish that actually the eviction is not because of that. So again, that's about challenging the council, about making those decisions. Okay. Yeah, so we'll move on from that. This again is all Zana's great work, so I don't want to... Yeah, so these are some of the comments that we've had. Actually, this is from a patient at the top. I guess you guys can read out. Inspired by your kindness, I'm this Christmas holiday volunteering with Crisis. So that's brilliant from the patient there. And I'll just go into the nurses one. I've noticed a real change in culture towards homelessness, most notably in the ending of the practice of discharging to the streets. When I worked at St Thomas's, because I was working there before here, we used to get what we call link nurses, and it's quite surprising how interested a lot of nurses are in supporting with the homelessness with our clients. So these are kind of the comments you will get from that type of nurse. So that's a really good one. Yep.
And I suppose just to say, I don't know why there isn't a last slide on Zana's presentation about the evaluation, and I think it's probably because it's not yet published. But there has been a really in-depth evaluation of the team, and one of the key things is it actually interestingly has shown a 34% reduction in length of stay for the patients there, and I do think that probably reflects the longer admission times for mental health patients. And another thing she hasn't put on that is that it did win the RPSYC Adult Care Inpatient Award this year, and why she hasn't put that on there, I don't know.
There's actually a lovely picture on the website.
It's a really lovely picture on the website. What does it say about lessons learned?
Okay, let's flick yep.
So what she said, that data collection is different and patchy. I think we covered that. A health needs assessment is important. Yeah, so I mean, I'm sure if it had been a mental health person going straight in there, they would have known that already, but it was quite interesting about the care coordinator thing, and also knowing where to focus the intervention. Academic collaboration is very beneficial, and I think in terms of getting that result out, it will be eventually.
Build a relationship with the wards is the key.
And aim to gather qualitative data is the last one, which is what you said. So there you go. That wraps it up nicely.